talk will be also about the criticism about the success of high efficacy therapies in progressive trials and what it means for patients. So I speak about the use of a blood-based biomarker and how we overcome the hurdle of aging as a confounding factor. So Klaus and Gavin, thank you very much for this invitation. Yes, so this is my disclosure statement, because my commitment to Novartis and Roche is far back. I didn't mention that on my disclosures, and I took the decision to use up the space here of the disclosure statement and not waste space. I want to put neurofilaments into the context of its use. And Stephen Hauser, a friend and mentor of mine, said relapses are not anymore in our focus because of the high efficacy therapies. But what is in focus is that we do not handle, and this is what I'm critical about the two compounds that were successful in progressive MS, this is a marginal success vis-a-vis how relapse suppression has functioned. So one way to overcome that in the near future is also to find out how we measure progression or evidence of disease activity in the future in our patients in a way that we can help and guide drug development as well as individual therapy. So who has heard about neurofilaments so far in their lives? Hands up, please. Okay, that's Klaus told me that will be a majority. Who is measuring neurofilaments in their practice or in their hospitals? Far fewer. Yeah? And that there's a good reason why that is. And the purpose of my talk is actually to help to overcome that. Neurofilaments come into in three flavors: medium, large, and light chain. They are structural components of the axon, so cytoskeleton proteins, and they are highly specific for neurons. So this is a signal you can catch up in serum, and you know it's coming from the nervous system. It is not specific for a disease. So every damage to the neural system leads to an increase and release of neurofilaments. And it was difficult to measure until recently, 5 years ago, and that has been overcome by the Simoa technique, which is a digital ELISA that increases the detection threshold by a factor of 100. So nowadays we can, because blood and CSF levels are highly congruent, refer to measurements in blood, which has obviously specifically for the United States advantage over lumbar puncture. You all know that emblematic picture from Bruce Trapp showing what happens in MS, demyelination, axonal disrupture, and then bulbing. And this is a success of translational medicine, I believe, in that this phenomenon can now be measured. The release of neurofilaments into the parenchyma, then in the CSF, and eventually into the blood is quantifiable with very simple techniques. Aging starts very early, and at the end of my talk I speak a little bit about pediatric MS as well, because aging starts at time point 0, at baseline. And I believe also that progression is a feature we should care for, whereas progressive MS is a regulatory feature or a regulatory entity. And what I mean with that is that neurodegeneration had already started pluperfect before a patient has her or his first bout. We see in radiological isolated syndrome, we see brain atrophy already has happened without having had relapses. So this is we're paying tribute to Jan Licke, who he was the first to publish on neurofilament light chain. So he looked into CSF samples of patients in function of the distance from a bout they had, and he realized that neurofilaments are strongly increased, and it takes about 200, 300 days to get back to normal. We still do not know what that means. Is that just because of a long half-life time of neurofilaments, or is it a continuous inflammation? So it's not just having a lesion being formed, but there is smoldering inflammation continuing to damage, and that is also a feature recognized driving progression. We are, together with Daniel Anthony from Oxford University, we are trying to find out about this phenomenon of this long half-life time. But Jan was the first to coin the perspective of using neurofilament as a biomarker. Many drug studies have been using neurofilaments as a tertiary endpoint, nowadays as a secondary endpoint, and I showed just two examples of that. This is the FREEDOMS and the TRANSFORM study, so comparing fingolimod versus placebo, fingolimod versus interferon, and the result is actually as expected. You see a huge difference between placebo levels that remain high, and after 3 to 6 months the lowering effect by the treatment, and this is less pronounced but still strongly significant when you compare an active compound, interferon. We know that this is less efficacious clinically than fingolimod. So in these settings you do not need to have normal data or a reference base, because the randomization is taking care of all the issues: sex differences, age differences, subclinical comorbidities, etc. And you produce a nice p-value, but this line here is somewhat bringing me to a blush. Nowadays, it's many years back we did that because we just set arbitrarily this is the level of healthy subjects. Now, Gavin had an editorial in Brain 2018 and said that neurofilaments will become the C-reactive protein of neurologists, and I strongly support that nowadays as well. What he brought up as questions is baseline measurement referring to future disability, is baseline or continuous measurement referring to clinical outcome, and drug therapy as well. And all these questions are nowadays with a yes. And I do not show you all the results here, but what is important about this editorial is that when he says that we should measure area under the curve, this refers to phase 3 trials or phase 2 trials, and not for individual use. And this is the pink elephant in the room. How do you come from a group level p-value to an individualized conclusion therapeutic decision making? Other features are validation of the assay systems. What I'm speaking about today is about the Simoa assay. Siemens and Roche Diagnostics and Biotechny are the three corporations that are developing their own neurofilament assay systems. They are not yet ready for practical use, but that is maybe coming next year. And another feature, the 20 years have been mentioned by Gavin in my introduction. We have lost a lot of time to bring what is basically evident to patients and physicians due to many reasons. Nevertheless, Jens Kuhle, my colleague, and I, we brought up this flowchart, how we use neurofilaments in clinical practice. So if a patient newly diagnosed is highly active, you do not need a biomarker, you have what you need to prescribe a highly active therapy. But if the answer is here no, you would measure neurofilament, and if the level is high, you have good reasons to go for a highly active therapy. Accordingly, with patients on disease-modifying therapies, if the neurofilament level is high, then prescribe a high efficacy therapy. That goes along the hit early, hit hard approach I'm an advocate for, and also supporting a quick switch to high efficacy therapies once you have the suspicion this is going into the to the wrong direction for the patient. Now the pink elephant in the room is what is NfL high? And that cannot be determined on the group level. That needs to be determined on an individualized level. And other than CRP, where we know what is the normal value, we do not know what that is for a neurofilament. So I list here the current development gaps, and I do not go too much into those. The regulatory acceptance, so having a label for the biomarker is the penultimate goal, and the prospective trials, assay optimization, and more preclinical data are a prerequisite to achieve that. I speak about the normative data and how we at least overcome that hurdle, I believe. In 2018, we realized that when we have spouses from the gene MSA patient cohort, that they increase with their neurofilament levels in function of age. That was a small cohort, and colleague Michael Kalil, they had then in 2020 a communication where it becomes even more difficult. This is not just exponential, as you may see. So how do you define normal levels of a 70-year-olds versus a 50-year-old, and compare their likelihood of being at risk for more neuronal damage in the future? We addressed that with a huge cohort of 5,300 persons, healthy persons, with longitudinal samples in part, and compared that with our 1,200 Swiss MS cohort patients. You see here the charts of results, and I want to go a little bit into the detail. If you transform with logarithmic transformation values, then you come from an exponential function into a linear function, and what we have seen is it is not log linear, it is hyper log here. So at 50 there is an additional increase of neurofilaments, and being my age, I know that brain atrophy has kicked in and is accelerating, and I should do more exercises and read more philosophical books to counter that. When you stratify then the different age sections, you see how this acceleration turns into numbers: 2.1, 3.1, 3.3% per year in increase of neurofilament in serum. The former speaker spoke about Z-scores. Do you know what Z-scores are? I didn't know for sure until our statisticians said we should go not for absolute values, but using percentiles or Z-scores, which is the identical thing. It's the deviation from the mean. So the 97th percentile is Z-score 2. The 84th is Z-score 1. And that basically stratifying your value in a way that it becomes age independent. And for those being still afraid about Z-scores, please read that review that relates to bone densitometry, where Z-scores are actually the standard. So I show you here what Z-scores 2, 1, and then below means in terms of this cutoff. I mentioned my blushing situation about what is normal value. So if we used once 30, Calabresi 16, and then 10, and we just chose 10 now as a very conservative threshold for being normal below and pathologic above. And it is quite evident that you do a disservice to those persons between 40 and 60 by saying above 10 it's pathologic, because the aging process has led to an increase of NfL levels not being pathologic. But my concern is mainly in this population between 20 and 30. You see a lot of those patients below 10, so being normal, having high NfL values, and they may be missed, or if you misinterpret the test, you do not prescribe high efficacy therapies, although they deserve it or must have it in this situation. Now, what is the difference between this chart and the next one? The discrimination between red, yellow, and gray is not anymore a clear one. You see intermixed here red dots. And why is that? We factored in the body mass index. So Claudia Schiffer's and Arnold Schwarzenegger's brains produce the same amount of NfL per time. However, the distribution volume of Claudia Schiffer is small and of Arnold Schwarzenegger is big. So that means that all of a sudden a fixed value becomes more risky for a person who is slim, because it means that the degeneration has a higher level than you would actually anticipate if you disregard that. This is a minor factor, but for an individual patient it may play a role. And that's why you see here, and in what I speak later about, the app you can have to look after your NfL results, in reference to our normative database, you can anticipate those patients who are at risk. This is what I mean with risk. So those in the yellow and in the red section had considerably more future events of disease activity as those in the lower ranks. Seeming the same was the case for future clinical signs, and if you like to have retrospective analysis, this was also reflected if you looked back into their history of the individuals. So which factors lead to elevated NfL Z-scores? It's clear that if you have, when you're younger, you have a higher activity than elderly ones, and I'll show you how that goes then longitudinally in a minute. And I don't want to carry calls to Newcastle, all that you know, secondary progression, relapses, number of gadolinium enhancing lesions, EDSS and T2 volume have something to do with disease progression and reflect into higher NfL values. What was interesting is that with this approach of a normative database, we can cross-compare different categories of compounds in their efficacy to attenuate neurodegeneration. So something that will never happen in lifetime, because the industry is not interested to make these head-to-head comparisons beyond the phase 3. But they are utterly needed from my point of view to show that high efficacy monoclonal antibody treatment is superior to untreated, but is also superior, and these are the 3 stars, to orals, and accordingly orals over platform therapies. So this is the longitudinal analysis of all of our Swiss MS cohort patients. Untreated patients have a slight lowering of NfL levels over time due to the lesser disease activity or lesser inflammatory disease activity. The other end of the story is high efficacy therapies with monoclonal antibodies that lead to basically reaching Z-score 0, which means normal to the population, and that comes very steep. It comes within 1 year, and it is steeper this effect than with oral compounds. And the platform therapies, interferons and glatiramer acetate, they have also an effect, but they have a rebound then. After a certain period of time, it seems that you have attenuation of effect on neurofilaments, and I personally conclude that indicates also lesser efficacy that will clinically manifest. The comparison of absolute values here in yellow and Z-scores on equal levels across all the study we have done. So you choose your threshold as you wish, at 11 or top 25, top 10, top 5% of the MS population, shows that with the Z-score you have a much higher prediction of future evidence of disease activity to come up vis-a-vis the absolute value. When you look at the right side, this is the reason why we do that. Just recently published a few days ago NEDA3 has become an endpoint in clinical trials, but I'm not so sure whether this is a good one, because 1 in 4 of those patients being NEDA3 for 2 years will experience the recurrence of disease activity in the next year, and it is actually a good idea to measure neurofilaments to pick those out with this kind of measurement. I show you 2 clinical use cases. Patients who were on the fingolimod and shifted to natalizumab, and you see the effect of natalizumab treatment in decrease of set scores or percentiles. They are depicted here both, as you prefer to read the data. Another patient was on the glatironate acetate and fingolimod and had a steady increase of EDSS scores, was then initiated on rituximab, and after 1 or 2 years, so it takes a little bit to manifest in this situation, has a strong decrease of the neurofilament light chain. And you can do that by your measurements of blood samples in the regular visits the patient has. So this is the app you can approach on the internet. You toggle in age, you toggle in your neurofilament measurement result, body mass or height and body mass index or height and weight. You push return, and then you see where your patient is actually landing, whether he or she is in the yellow or the red zone, and also there's a numerical readout of the result. I want to close with pediatric MS. This is even more complex. So this is a paper from Jutta Gärtner, and this is actually not on MS and spinal muscle atrophy. I show that because both groups have acquired normative data of persons between 0 and 20 years old, and it shows a U-shaped pattern. So in order to apply in the future also the risk of disease activity in terms of increase of neurofilaments, we need to create for this age section another normative database. So in summary, I have shown you that the NfL increases by age, and we can overcome that hurdle with Z-score and percentiles. I advise not to use fixed cutoffs as we did it before, because it impedes the interpretation of intra and inter-individual values. The normative database is actually accessible to you, including the feature of body mass index. We are working to refine the normative database and looking into subclinical internal medicine diseases, whether they impact the level. I believe that with that tool, it's an important contribution to anticipate progression. I'm not a fan of progressive MS, but progression is indeed what we need to tackle as physicians. Thank you very much for your attention. This is our MS group, and Jens, my colleague, who is leading the Swiss MS cohort. Thank you.